Thank you and welcome to Module 6. I am Allison Moliterno and I will be the moderator of this session. Our Module 6 session is Novel Pathways and Targets in the MPNs, Moving Beyond JAK2 Inhibitors. As I mentioned, I'm Allison Moliterno from Johns Hopkins University School of Medicine. My co-modulees are Lucia Masarova and Naveen Pavaraju, both from UTMD Anderson's Cancer Center in Houston. The focus of this module will be to understand the context of the JAK2 mutation, the targeted therapy of JAK2, and also combinations with JAK2 inhibitors and moving beyond JAK2 inhibitor therapy. Well, we'll get started now, and I will be the first speaker. It's a pleasure and an honor to be here today with you. I'm Allison Moliterno, and I'm a hematologist at the Johns Hopkins University School of Medicine in our hematology division. And today I would like to focus on myeloproliferative neoplasms and focus on their context, pathways, and targets. And this hopefully will launch us into the subsequent talks with Dr. Masarova and Dr. Pemmaraju in this session. So just to review, this audience does not need this reminder, but often I do. The JAK2 kinase is on chromosome 9p24 and it's highly conserved across mammalian species. The gene product is a protein tyrosine kinase that transmits receptor ligand signaling along multiple pathways shown in this cartoon. It is important for the hematopoietic ligand receptors for EPO, thrombopoietin, GCSF, and IL-3, and it has multiple signaling pathways in myeloid blood production, but particularly STAT3 and STAT5, PI3 kinase, and MAP kinase. Now, the acquired somatic mutation of JAK2 occurring in the discovery in 2005 has shown us that mutations that enhance the kinase activity, and primarily V617F, shown here in this red cartoon, these are spontaneously occurring mutations. They never resolve, and we do know that they have given advantage to the stem cell such that clonal expansion of JAK2 mutation occurs. JAK2 mutations associate with 9p-UPD, which is a mitotic recombination event that generates homozygosity within a cell. So again, we have an additional variable of not only an activating mutation in one allele, but both alleles can be affected. That translates into our patients to a very varied distribution of JAK2 clones that could be wild-type JAK2, single copy mutations, so-called heterozygous, represented here in blue, and homozygous, represented in red in this clonal distribution. As we know in the bone marrow, if you have no JAK2 mutations indicated by this row of wild-type stem cells, your JAK2 variant allele fraction or allele burden will be 0%. As you accumulate mutations in the heterozygous state, you can have a low allele burden. And then as mutations become homozygous, indicated in red, you can have within an individual both heterozygous and homozygous mutations, or even completely homozygous mutations in the stem cell pool. And this again translates to really a continuous variable of allele burden in an individual over time and within a population of JAK2 positive mutation patients. That translates to clinical disease differences. So lower clonal burdens show us that there's associated with clonal hematopoiesis or essential thrombocytosis. And as homozygosity and clonal burdens rise, we associate that with development of polycythemia vera. And when we have very high clonal burdens, that can also be associated with myelofibrosis or post-PV myelofibrosis. So the amount and the distribution of these clones does matter and translates to variable clinical diseases. Again, on this timeline, I show the discovery of JAK2 V617F and MPN in 2005. And then quickly over the first few years of the discovery, we found that it really mattered very much whether a person has the JAK2 mutation or not in a specific phenotype. So for instance, not long after the JAK2 mutation was discovered, investigators went back to look at their studies and showed that when we compared, for instance, thrombosis risk in ET versus PV, if you were JAK2 positive, you had a much higher risk of thrombosis compared to JAK2 negative ET. After the CALR mutation discovery, again, in ET, the differences between who was JAK2 positive really translated to an increased thrombosis risk. This became such an important risk factor, whether you were positive or negative for JAK2 in terms of risk, it became incorporated into the IPSET criteria as an independent risk factor. And we know now that lifetime thrombosis risk in PV and in the MPN in general, by very large population studies, is intimately tied to not only whether you have the JAK2 mutation, but also even within PV, how much of the JAK2 mutation you have. So a recent study showed that JAK2, V6, and 7F allele burdens greater than 50% in PV had a higher thrombosis risk. So as we've heard earlier in this meeting, we know that JAK2, V6, and 7F subtends really a spectrum of MPN. We know that mutations recapitulate human disease, for instance, in murine models. So if you put the JAK2 mutation in a mouse, whether it's a knock-in or a transgenic, you will recapitulate features of MPN, high cell counts, bone marrow hypercellularity, and fibrosis even. We also know that the genomic burden modifies the presentation and evolution. So in individuals, as JAK2 allele burden may increase, we can see these transitions from ET to PV or from PV to myelofibrosis as we gain more JAK2 allele burden at the stem cell level. And this is also recapitulated in murine models, where again, the more JAK2 you put into an animal model, the higher grade disease it will show us. So now we have to get back to the context of the JAK2 mutation, both of its acquisition and really why this would matter. Because as we think about how we're going to treat patients, we have to understand, well, are all patients the same in terms of why they got it and what factors that modify how this translates across, the mutation translates in their lifetime. So for instance, now that we have a target to really measure the JAK2, V6, and 7F in a uniform population of patients, we know that the host really matters in terms of how JAK2, V6, and 7F, why you get it. Meaning we know that there's a higher family history of MPN in individuals who have an MPN, and indicating that there are heritable factors for the acquisition. We know that certain haplotypes in the JAK2 gene itself, in the TERT gene and ATM, have been associated with particular increased risk in an individual or in a family. And more recently, along the inflammation lines, IL-6 receptor variants have been described that increased risk of developing JAK2, V6, and 7F. And certainly we know that male sex is a risk factor for getting JAK2, V6, and 7F, and aging. We also know that there may be environmental factors that increase the risk of obtaining. And this is important to understanding why a patient may have gotten this and what their course might be. For instance, the outbreak investigation in Pennsylvania in Hazleton indicated that there may be a higher risk of developing PV due to potential toxic agents in the area. There's been concerns about Agent Orange and exposures at Camp Lejeune, potentially as increasing exposure risk. And we certainly know from many epidemiologic studies that tobacco exposure is a big risk factor for acquiring JAK2. Then there's the issue of, is there inherited genomic instability, or getting JAK2, V6, and 7F, does this mean that you may have a cancer predisposition syndrome? We know that individuals who have JAK2, V6, and 7F have higher risks of melanoma, breast, or bladder cancer. We know that in genomic instability syndromes such as ataxia, telangiectasia, neurofibromatosis, and BRCA, that there is an increased risk of developing JAK2 disease. And then finally, in my own practice and many discussing here, and in epidemiologic studies, there does seem to be a connection between autoimmune conditions and inflammation, or potentially an immunocompromised state, is allowing the JAK2 mutation to occur. So many patients develop this, or it's unveiled during pregnancy. Or in my own practice, I have several patients who are post-splenectomy who have developed JAK2, and also associations with autoimmune or inflammatory syndromes as risk factors. So again, quite a varied mix in terms of who you are, what you've been exposed to, whether you have a predisposition to developing genomic instability, and also inflammatory pathways now that have become so important in our understanding of how we get JAK2. So critical to this in understanding how we're going to target JAK2 or treat JAK2 is treating the mutation itself in a cell or treating the mechanism of how it allows it to expand. So as we talked in these earlier, showing these stem cell compartments with variable amounts of JAK2 heterozygous and homozygous clones, we know that mutation burden, age, stem cell advantage, the microenvironment, and inflammatory cytokines that we've heard earlier seem to allow this expansion to progress forward and increase allele burden. And so really probing the mechanisms of this is going to be very important as we target this new understanding to treat or suppress the disease, or even potentially prevent it. And we've learned quite a bit about JAK2 from studies in clonal hematopoiesis of indeterminate potential, so-called CHIP. And this beautiful review article from David Steensma a number of years ago now. But again, showing us that CHIP is defined as an acquisition of mutations at low allele burden, and over time, these can start to expand because of advantageous or changes in the environment where these stem cell clones live. And we know that JAK2, V617F, is the third, fourth, or fifth most common clonal hematopoiesis lesion in many studies now. We know that CHIP is defined as the absence of a WHO criteria for a diagnosis of blood neoplasm and absence of cytopenias. Importantly, we've learned from JAK2 CHIP that there's certainly a higher hazard ratio for MI compared to the other most common CHIP lesions in DNMT3A, TET2, or ASXL1. And again, this hazard ratio for JAK2 in the study by Jaiswal is much higher compared to ASXL1, TET2, or DNMT3A. So again, really driving home the importance of understanding how JAK2 occurs and also consequences. What I showed you earlier was the timeline for the JAK2 specific risk in MPN after the JAK2 discovery in 2005 and over these next 15 years. But below this now is really the recognition of JAK2 specific risk in clonal hematopoiesis. Again, clonal hematopoiesis meaning that you don't necessarily have an MPN, a full-blown MPN, but you do have the presence of the JAK2 mutation. And really not long after the 2005 discovery, a group reporting from China and about 3,000 individuals from a hospital population showed that JAK2 prevalence was about 0.1%. And there was a suggestion that it influenced blood counts even at these low levels. Then the Danish studies by Brigitte Nielsen, looking at 10,000 Danish population or 40,000 Danish population, showed that, again, these very low levels of JAK2 CHIP increased MPN risk, mortality risk, and cancer risk, and also thrombosis risk. Finally, a really huge study of the 100,000 US population, again, that I showed you earlier, showed a coronary heart disease risk and thrombosis risk. And then the most recent Danish study last summer, 20,000 Danish suburban population patients, showed also a prevalence of JAK2 CHIP and an association of stroke and VTE risk. So understanding what CHIP means in the context of CHIP and what the associations are will also inform us in the MPN population at large. Again, focusing on these very large studies by Nielsen in 2011 and 2012, and then Heinz from the 23 and MEET participants, and then Corridor, the Danish suburban population just mentioned, We can see the prevalence of JAK2 chip, again, very low, 0.2 to 0.1%. Using a very highly sensitive droplet PCR assay, we see it can be up to 3%. So a difference in assay increases the sensitivity. But again, these associations of who got chip, we have increasing age, male sex, and cumulative smoking. So again, the same risk factor that we have for MPN, getting JAK2 is really powerful in developing JAK2 chip. The Nielsen study also showed in different population, older age, male sex, and smoking. And then finally, in the most recent Cordura study, older age, male sex, and smoking. And then, of course, the associations, any cancer rate, hematologic cancer, ischemic heart, and VTE, and higher VTE risk. So again, the JAK2 chip context and the MPN context share many features of risk factors for acquisition and also risks of morbidity. And just to bring this home even more, in the Cordura paper, we have the 20,000 Danes that tested 19,000 or so that were negative for JAK2, who had JAK2 allele burdens of less than 1% or greater than 1%, and then those that were between 2 and 100% here. What we have here is the total N here, so again about 19,000. Here there was about 500. The JAK2 chip that was greater than 1 but less than 2 was about 60, and then the very few MPN patients that actually were collected in this group. And what I can show you here is the corresponding average white cell counts, hemoglobins, and platelets. So again, even at this very low JAK2 chip level, platelet count was significantly higher compared to the non-mutated group, as was white cell count. And then as the more JAK2 chip you had in terms of variant allele fraction, the higher the platelet count. And then again, compared to the 16 MPN actual patients they pulled out of this population. Corresponding to this is the VTE and the stroke risk. So again, you can see at super low levels, there was not an increased risk of VTE or stroke compared to the control population. But once we started getting JAK2 levels greater than 1, we saw an increased significant risk of VTE, odds ratio of about 3. And then in the MPN group, we had odds ratios of about 6 in the venous thrombosis and 3.5 in the stroke. So again, JAK2 context, the context of whether this is CHIP versus MPN, sub-10s influence on counts and stroke risk and thrombosis risk. So what have we learned from CHIP about the MPN? We've learned, what I have here is our Hopkins cohort, where we have the female age at MPN diagnosis, and again, this is JAK2 positive MPN, and you can see it's quite a broad range of ages. And then here we have male age at MPN diagnosis, again, more tilted to the right, like CHIP is, where prevalence of CHIP in general is more male and older. In the female MPN context, however, we have a lot of younger women presenting with MPN. So we have some things to try to understand about acquisition. We know CHIP prevalence is low in general in younger females, and CHIP prevalence is higher in males and associated with these lesions of aging. Yet in the MPN world, we have a little bit of a contrast here. We also know in terms of the JAK2 chip, we have a high rate of venous thrombosis as patients age. But again, in the female MPN world, we actually have a higher risk of venous thrombosis in the younger age group. So there must be particular risk factors for developing particular types of chip and contexts versus MPN that are important to understand. So finally, as I compare, contrast in this table in the MPN context, we actually have a prevalence of more females than males for JAK2 V617F, whereas in the CHIP context, we have more males than females. I mentioned the difference in variant allele frequency, generally accepted less than 2% as a CHIP context, whereas greater than 2% is an MPN context. In both states, we have increased in arterial thrombosis risk. We know that whether we're CHIP or MPN, that the variant allele fraction will increase over time. Maybe not at the same rate, but it will increase in both. And again, the mechanism of this clonal expansion needs some real explanation. And I have here AIGI, which means aging, inflammation, and genomic instability are all factors that may influence this increase. We've talked about the venous thrombosis risk increased in both, and again, the mechanisms behind this. We certainly know that white cells and platelets and hemoglobin are all adjusted up with both of these contexts, and both of these contexts are associated with mortality, heme cancer risk, and other cancer risks. And again, the mechanisms behind these risks really are shared between both of these contexts. Whether mortality is due to other cancers or thrombosis, or this evolving to a cancer. The mutation burden is a mechanism for the hematologic malignancy cancer risk, and then other cancer risks that we've talked about that are host or exposure related. So now we have come to understand that JAK2 V617F exists in some contexts that may perhaps are overlapping or part of a spectrum. In this red circle here, I have, if we could imagine all of the individuals who test positive for JAK2 V617F, regardless of how large their allele burden is or variant allele fraction. And we can see here that the majority of individuals who test who have low levels and are termed clonal hematopoiesis. We think perhaps only up to 3% of individuals who have clonal hematopoiesis will actually have that evolve into an MPN. And again, I have here that most of the individuals with PV will fall into a JAK2 positivity, whereas about half of individuals with ET and half of individuals with PMF will have the JAK2 V617F mutation. So again, these overlapping circles of clonal hematopoiesis and then frank MPN all are connected to each other. And we know that genomic burden modifies presentation and evolution and thrombosis risk, whether you're in a clonal hematopoiesis phase or an actual MPN phase. And so here I have the JAK2 genotypes as we've gone through, their allele burdens, and then the factors that we've heard about earlier today about the clonal expansion, whether it's aging, inflammation, or additional lesions associated with CHIP, and that how this translates really to increasing allele disease burden and morbidity. So I'd like to close with a few thoughts. The JAK2 V617F discovery has certainly enlightened our understanding of stem cell physiology in the MPN. It's ushered in a new field of clonal hematopoiesis, and also it's been very important to thrombosis research. We've had now the luxury of this discovery informing us how to develop and use JAK2 inhibitors. They are fabulous to reduce blood counts. They don't seem to be leukemogenic. They reduce thrombosis risk, improve symptoms, and in some cases may even suppress JAK2 V617F. But they are very much targeted just at this one process, intracellular process. And we have FDA approval for 2 agents. But really, what we now have to, as we move forward, we have to think beyond just MPN and our cartoon of the JAK2 signal transduction cascade. We have to realize that MPN and CHIP really exist in the context of many risk factors that I have centered here: inflammation and aging, that both drive MPN acquisition, and also MPN drives this whole process forward, and that CHIP and MPN are very intimately tied, and that they share risk factors and evolutions to all these other processes. And so if we're really going to address MPN, we need to address the risk factors behind these other processes. So genetic discovery has really transformed MPN diagnosis, prognosis, and risk stratification and thrombosis research. The global risk assessment will include disease-specific factors and patient-specific factors. driver mutations and the variant allele fraction does matter, and the causation is both direct and indirect. And we also have now learned that JAK2, V6, and 7F is implicated as a thrombosis risk factor, even in the so-called non-MPN populations. So when we think about targeting new pathways, we have to think about both for prevention and for treatment. We need to understand and interrupt inflammatory signaling. We need to understand exactly how tobacco drives acquisition and potential expansion of JAK2 clones, and really understand if this is different from this inflammaging pathway, something very unique that we need to understand. We also need to look into diet and anti-inflammatories as another ways to interrupt this inflammatory signaling. We have refined prognostics that can help us mitigate risk and apply genetics to understand targeting pathways beyond JAK2. And you will hear about therapies beyond and in combination with JAK2 inhibitors, which I think is going to be really wonderful areas to investigate. So I'd like to thank you very much for your attention, and we'll move on to our next presentation. And our next speaker will be Dr. Lucia Masarova. Dr. Masarova is at the MD Anderson Cancer Center in Houston, Texas, and her title is Targeted Therapies in Combination with JAK2 Inhibitors.
Hey everybody, and thank you for having me here today. I'm happy to be joined this wonderful Texas virtual MPN meeting. I will talk today about the combination of ruxolitinib and novel targeted therapies. As you can see, the patients with myelofibrosis have quite complicated disease pathology with multiple pathway involved, which give us opportunity to use different targeted agents. And also it raises increased opportunities to have resistance to monotherapy. In my talk today, I will focus on agents. They are highlighted in the blue boxes, especially epigenetic modifiers, BET inhibition and azacitidine, as well as BCL2 and BCL-XL inhibitor Navitoclax, and PI3K inhibition. I will present updated data shown in ASH of 2019 and EHA 2020. The probably most exciting topic this year has been a combination of agent called CPI-610, which is a bromodomain inhibitor or BET inhibitor, which is a very important transcription or modifier pathway involved in patients with myelofibrosis and holds a potential for disease modification. By inhibition of BET protein, so we could achieve downregulation of pro-inflammatory cytokines, as well as inhibition of megakaryocytes differentiation, possibly improving outcome of these patients and avoiding treatment resistance. The most exciting agent has been CPI-610 as a best-in-class BET inhibitor, more potent and selective molecule, which has been evaluated in patients with myelofibrosis in a phase 2 manifest study, which had different arms. These slides show a design of the manifest study as officially published. I will focus today on the updates of the combinational arm, which is the middle one, shown add-on approach to ruxolitinib in patients with suboptimal response, where CPI-610 is added to ruxolitinib, and that arm is divided into two cohorts, cohort 2A and 2B based on transfusion dependency. And primary endpoint, except for improvements in spleen volume reduction, also included percentage of patients who could change from transfusion dependent into transfusion independent. And then arm 3, which is at the bottom part, which is a combination of ruxolitinib and CPI-610 in frontline previously untreated myelofibrosis patients with anemia. And primary endpoint is spleen volume reduction by 24 weeks. This slide shows the latest updated demographics and study features of both arms. On the left, you could see add-on ruxolitinib approach with CPI-610, which showed updates on 70 enrolled patients after median duration of therapy of 28 weeks. And it's obvious that patients were added on the trial after having ruxolitinib for more than 6 months, and there was over 76% of those patients. About 74% were anemic with hemoglobin less than 10. On the right side, you could see update on patients being on frontline approach of combination of ruxolitinib and CPI-610, which reported on 64 enrolled, however, 30 evaluable for first endpoint, and similar median duration of therapy of 24 weeks. About 40 and 10% of the patients discontinued on both arms, more on the left arm with add-on approach. However, treatment-related discontinuation was only up to 10% of patients on both arms. The yellow boxes show severe toxicity noticed on both arms. As you can see, the most significant, however not frequent, was cytopenia, with the add-on approach to mostly thrombocytopenia in about 24% of the patients, and with the upfront approach anemia in 17%. Non-hematologic grade 3 or more higher adverse events were not frequent and only observed in about 8% of the patients on the add-on approach with diarrhea and gastrointestinal upset, and only about 5% with infection on the upfront combinations. So overall, the combination has been well tolerated in suboptimal responders as well as on the frontline approach. This slide is showing best spleen volume reduction and improvements in total symptom score on the add-on CPI-610 with ruxolitinib. The left part with the orange bars is showing patients who were enrolled with transfusion dependence. And on the right side, the blue bars, patients who were transfusion independent. As you can see, up to 35% of the patients were able to convert from transfusion dependence into transfusion independence. And best spleen volume reduction by 35% or more has been achieved in about 20% of all patients in both arms, regardless of transfusion dependency at the enrollment. And improvements in more than 50% of total symptom score has been observed in even more patients, up to 46% on the transfusion independence and 37% transfusion independent patients. Very exciting results also came from the upfront combination of CPI-610 and ruxolitinib in previously untreated patients. Here you can see summary of the best spleen volume reductions and total symptom score improvements by 24 weeks. The left upper bar showed best improvements in the spleen volume reduction, which is achieved in about 60% of those patients. Similar number noticed for improvements in total symptom score. These results are definitely superior to single agent ruxolitinib in the approval comfort studies. The combination did not lead to any significant anemia. On the contrary, hemoglobin level remained very stable over time, as is shown on the right mean hemoglobin graph bar. Now I will move to the second trials, combination of azacitidine and ruxolitinib in patients who were previously untreated for myelofibrosis. This study has been already published, and I will only show the latest update from ASH 2019, which enrolled 60 patients of the combination after median therapy of over 2 years. This study was designed as single agent ruxolitinib for the first 3 months, and azacitidine will be added after cycle 4 at 25 milligrams per meter square with possible updose based on efficacy. The overall responses reported on the combination, according to official IWG MRT criteria, were at 75%, and 50% palpable spleen reduction at 24 weeks, which equals 35% reduction by imaging shown on the previous study, was noticed in 60% of these patients. About 1/3 of responses were only seen after azacitidine was added. The update of this study included that the median duration of responses has not been reached, with this median follow-up of 35 months. And interesting is the observation of improvements in bone marrow morphology, which has been reported in over 50% of these patients and has been sustained with median follow-up of 28 months in all but 1 patient. You can see the toxicity in the yellow box, and about 20% of the patients get new grade 3 cytopenias on the combination. However, non-hematologic toxicity of grade 3 or more were less frequent. Now I will show updated data on another exciting agent, which is combination of BCL-XL and BCL2 inhibitor Navitoclax and ruxolitinib, again in patients with suboptimal response to single agent. Using BCL-XL and BCL2 inhibitors, especially Navitoclax, is very rational for patients with myelofibrosis. It has been known that both of these pathways are upregulated in these patients and therefore causing more resistance to cell death. By using BCL-XL and BCL2 inhibitor with ruxolitinib, we can possibly achieve enhanced efficacy and overcome ruxolitinib resistance. This has been also a phase 2 study in patients with chronic myelofibrosis who were taking ruxolitinib for more than 12 weeks, and patients had to be on a stable dose of 10 milligrams or more for over 8 weeks and still have persistent splenomegaly, which was palpable with more than 5 centimeters below costal margin. The design of the study is shown on the left as adopted by official reports from Claire Harrison published in EHA 2020. And the primary endpoints on the right included improvements in spleen volume reduction by the week of 24. Navitoclax was explored in a stepwise fashion where patients started taking 50 milligrams daily up to maximum tolerable dose of 300 milligrams daily. Summary of the demographics and study design by the time of last report is shown here. The study reported on 36 enrolled patients with 34 treated and available for response after median duration of treatment slightly over a year only. You could see that over 70% of the patients were able to receive maximum dose of Navitoclax of 300 milligrams daily. However, the reduction of the dose was frequent and occurred in over 80% of the patients, mainly due to thrombocytopenia, which is worrisome unexpected side effects of Navitoclax. However, treatment-related adverse events on the combination attributed to the Navitoclax therapy were only reported up to 9% of these patients. The most common side effects shown in the yellow bar of grade 3 or more include thrombocytopenia and anemia. Thrombocytopenia, as expected, occurred even a grade 3 or more in over 50% of these patients in combination, however, was manageable with dose reductions. On the contrary, anemia was not significant, and mean change in hemoglobin from baseline is shown on the right, possibly implying that Navitoclax could not worsen anemia caused by ruxolitinib inhibition. Non-hematologic adverse events of grade 3 or more were not common, and the combination has been well tolerated. These updated bars are showing best percentage change in spleen volume reduction and total symptom score by 24 weeks on the combination, and suggest that Navitoclax could overcome ruxolitinib resistance in patients who take ruxolitinib on a stable dose and have suboptimal response. You can see that about 1/3 of the patients could achieve further improvement in spleen volume reduction by 35% or more than 50% improvement in total symptom score. Next, I will move into the last targeted agent explored in combination with ruxolitinib, and that is PI3K inhibitor parsaclisib, also used in patients with suboptimal response to ruxolitinib. PI3K pathway has been shown to play important role in pathogenesis of patients with myelofibrosis, and parsaclisib is a novel, highly selective PI3K inhibitor with more favorable one-daily dosing. This was again a phase 2 study in patients with suboptimal response of ruxolitinib who has been on ruxolitinib for more than 6 months on a stable dose of more than 8 weeks prior enrollment, and still had either persistent splenomegaly of 10 centimeters or more, or smaller persistent palpable splenomegaly and related MPN symptoms. The study design is shown on the left side of the bar of the graph, as presented by Jakub and colleague on EHA 2020. On the last enrolled patients of 53 on the study, you can see the study explore 2 different dosing. One shown always in the blue will be daily or weekly dose, which reported on 33 patients, and the other one all daily dosing on 20 patients shown in the green. The primary endpoints also included improvement with spleen volume reduction, however, this time by 12 weeks. This slide summarizes the last updates of demographics and study duration, which was shown by the colleagues in EHA 2020 on 53 annual patients on the combination, 47 available at 12 weeks for responses. Median duration of therapy was 28 weeks. On the right, you can see swimmer plot showing currently ongoing patients in green and patients who stopped therapy for various reasons. Overall, 40% discontinued treatment, 11% due to treatment-related adverse events, which was more common in the daily or weekly dosing in about more than 50% of these patients. On the contrary, all daily dosing has been more safe, and treatment-related discontinuation due to adverse events occurred in only one patient. The overall summary of treatment-related adverse events is shown again in the yellow box. And you can see the most frequent was new grade 3 or more thrombocytopenia in 1/3 of the patients. Non-hematologic adverse events of grade 3 or more, which are worrisome side effects of PI3K inhibition, were not noticed in this combination, and therefore the combination has been safe, but mostly for the all daily dosing schedule. These slides is showing the best percentage change in spleen volume reduction and total symptom score in 12 weeks. On the left is best percentage change in the spleen volume. You can see the all daily parsaclisib dosing, which has improved efficacy and toxicity, is shown in the green, and best reduction in 25% of a spleen volume was noticed in about 24% of these patients by week 12. On the right is improvement in total symptom score, which has been slightly better, and up to 40% of the patients achieved more than 50% reduction in total symptom score by 12 weeks. So in conclusion, the combinational therapy of targeted agents and ruxolitinib are very exciting topic of these days, possibly improve efficacy of single agent and reduce or overcome resistance that could come from single agent ruxolitinib. We all awaiting updated follow-up of this study, as all has shown treatments combination by 28 weeks. Probably the most exciting would be frontline comparison of ruxolitinib placebo versus ruxolitinib CPI 610, which is planned for the second half of this year. Here I will conclude, and thank you very much for your attention.
Thank you very much, Lucia. Now our next speaker will be Dr. Naveen Pavaraju. Dr. Pemmaraju is one of the organizers of the MPN Texas Speaker Series and is at the University of Texas MD Anderson Cancer Center in Houston. Dr. Pemmaraju will be talking about novel targeted therapies beyond Jacktail inhibitors. Dr. Pemmaraju.
Well, everyone, thank you so much for joining us as one of the co-founders of the Texas Virtual MPN Workshop, our first annual meeting. I'm so happy to deliver this talk to the group, which is on novel targeted therapies beyond JAK inhibitors. So as we begin, as you've heard from the other speakers, the JAK inhibitor landscape in our field has really exploded over the last couple of years. We have the two approved agents that we know well, ruxolitinib and fedratinib, both approved, and then a host of other agents that we've heard about throughout this conference in late stages of clinical development by our colleagues. Of high interest to me and several of you is the concept of adding a novel agent or add back strategy, which we've heard about as well. And on the left, I've tried to give you an overview of some of the older ones. We'll call that version 1.0, hypomethylators and IMiD agents in particular. And on the right, as we've started to hear about in this meeting, some of the newer agents, heat shock protein, BCL-XL, bromodomain, and others. And then, of course, what's old is new again, using growth factors, interferon agents, and other novel agents in combination. But the real subject of my talk is the brand new, completely novel agents outside of JAK inhibitors. Kind of made this outline for our presentation here today. I'll try to hit on most of these in this 10-minute presentation, including promoters of apoptosis, so SMAC mimetics, BCL-XL inhibition, How about this concept of targeting the microenvironment or possibly even the leukemia stem cell with CD123 inhibition and heat shock 90 inhibition? I won't have time today to talk about the TP53 pathway that Dr. Mascarenhas and others, Dr. Hoffman, have pioneered with MDM2 inhibition. And then we'll focus some of our thoughts on some of the brand new agents targeting fibrosis, cytokines, epigenetics, and then a very intriguing novel agent, that of telomerase inhibition with the imetelstat agent. So focusing on some of the newer agents that have been discussed at EHA and ASH from last year, this is a program that I've been leading with the agent known as tagraxofus for SL401 targeting CD123 in patients with higher risk MF. We presented this as EHA oral. The concept here is that in myelofibrosis relapsed after JAK inhibitor, there are no approved therapies, and some of these patients have thrombocytopenia, as we know, that limit the use of the JAK inhibitor in the first place and mark a poor prognostic patient. Also, some of these patients may have a monocytosis-rich subset that marks it separate from CMML, but also thought to be a poor prognostic feature. So this agent, tagraxofus, let it roll off your tongue, targeted cross or linked fusion protein, SL401. As you all know, I was fortunate to lead this drug to FDA approval in New England Journal last year for the very rare BPDCN myeloid malignancy. But of interest, the CD123 IL-3 receptor alpha is really overexpressed in a wide variety of both myeloid and lymphoid malignancies, including MF. So this study is 32 patients, interim analysis, well-tolerated drug, I would say overall, except it is IV, 3 days, first cycle requires hospitalization. And as we saw in the BPDCN experience, there's a black box warning for the capillary leak syndrome. Only a few cases of CLS thus far, no deaths attributed to this, but as we expected, you do see increase in the LFTs, thrombocytopenia, low albumin throughout the patients being treated. In these first 32 patients, there have been several patients with both spleen size reductions as shown here, as well as TSS or symptom burden improvements. Most of these are not yet meeting the criteria for IWG strict response over 12 weeks, but at least the start and hint of early response and activity. I think most intriguing about this and several of the agents I'll show you is the overall survival curve, which is better than possibly historically expected. Most of the studies in our field are showing something like 14 to 28 months of median overall survival in relapsed patients. Here you're seeing 30.5 months in these first 32 patients. Let's, of course, follow together. This is an ongoing phase 2 trial. And so what we've concluded so far from the tagraxofus and MF experience is that there is feasibility of targeting CD123 for the first time in our patients. Of course, ongoing study, continue to enroll, watch the toxicity profile carefully, and then to take a look to see if these high-risk subset groups, thrombocytopenia, monocytosis, CD123 overexpressing, and those patients in accelerated or blast phase, can they benefit from this agent? And of course, future directions will be, what about combination agents, hypomethylator, JAK inhibitor, et cetera. So turning our attention to another program that I've been able to lead is the LCL161. This is a novel oral weekly SMAC mimetic. This was an investigator-initiated study just recently completed at our center here at Anderson, 50 patients overall treated. Again, I think the background for these novel agents is important to discuss. We're looking for agents that are new and different from JAK inhibitor, that can stand alone as a single agent. And we consider these patients to be poor prognosis patients, something like 14 months or up to 28 months in the recent Palandri paper, and agents that can be given with platelets even down to 0, where that should not matter. So we launched this investigator-initiated study. As I mentioned, 50 patients treated, 30% overall response rate in a primarily relapsed patient population. The majority of the responses are shown here. They are majority symptom burden response, but importantly and surprisingly, 6 patients with IWG confirmed anemia responses. This agent was interesting. It's an oral agent, easy to give, fairly well tolerated in this older population of patients. Again, notably overall survival here as shown, not reached. I will say with the caveat that these are not all relapsed patients, but primarily relapsed patients. And again, the concept here, as you think about this novel agent, first in MF study, there were long-term responders, several of whom were ongoing after 1-2 years plus. The 6 anemia responders, The clinical correlatives have been intriguing, showing on-target CIP1 inhibition, which is the purported mechanism of action in all responders, and a developing story that we're trying to work on, which is that most of the resistance or progression patients appear to have XIAP increase, and so we'll see how that story plays out. Toxicities in all of these novel agents, very important. This one's an oral weekly drug, so convenient, can be taken at home, but there was a distinct grade 2 fatigue syndrome different from the underlying MPN symptom burden and did lead to the majority of dose reductions and patients coming off study with this particular phenomenon. And again, future directions, I'd love to see more correlative studies, combination studies in the future with this agent. So as we look at other abstracts from ASH and EHA, one that caught all of our attention was the phase 2 ongoing experience with luspatercept for patients with MF-associated anemia. Now we know this agent has been approved now in beta thalassemia in a subset of patients with MDS and now being actively pursued in our field. Intriguing study design, complex and elegant as shown here, including arms for both including the JAK inhibitor and not. Primary and secondary endpoints shown here, really mainly emphasis on transfusion independence and transfusion dependent states. I think what's important and interesting is that you have a subgroup of patients not receiving JAK inhibitor and those on a stable dose of ruxolitinib. I find that to be a brilliant trial design, reflecting sort of what the real world use would be eventually of this agent. And overall, what you see is the achievement of primary and secondary efficacy endpoints in this novel study, with the key being that the median duration of red blood cell transfusion independence, 12 weeks or greater, was 32 and 39 weeks for cohorts 2 and 3B respectively. Another exciting agent that we all must follow together, many of you at this conference are leading, is the BET inhibition program with the MANIFEST study. This is the phase 2 ongoing CPI 0610 presented at ASH. We've seen some of the data in the relapse setting in combination, but very exciting was the initial results of the first 15 patients treated in the frontline setting as shown here with an SVR 35 at 12 weeks of 80%, 12 out of 15. Of course, we'll follow these over time, and we know some of these early results and reports can show a decrease over time, but nonetheless, a nice signal early on in a well-tolerated agent. Some of the keys will be in the ongoing study to see how this drug performs in combination with JAK inhibitor by itself, and then again in the frontline setting as we're showing here. Also strikingly, symptom burden improvement shown with the bromodomain approach. So this is a realization of preclinical data, right, in AML, MPN, myeloid malignancies, that bromodomain may possibly have activity either by itself or in combination with JAK inhibitors. So I personally am very excited to follow this program as it moves on. A similar program will be that of inhibition of BCL-XL with the Navitoclax agent, which I am personally involved in. This is the phase 2 ongoing study, and we've shown this data at ASH. Strikingly, Navitoclax does show spleen size reduction. These are patients, again, this is the add-back strategy, but I'm showing it here, this in the bromodomain, because these agents will be investigated soon as single agents beyond JAK inhibitor or even in the frontline setting. And you can see here an SVR 35 at week 24 of 30%. The majority of patients, as you know, will get thrombocytopenia, although almost none of these had or will have a bleeding event associated with that. There is also associated symptom burden decrease. So for these agents, bromodomain, BCL-XL, the key will be as they go into phase 2 and phase 3 studies to see how they perform as single agents or in combination in the frontline setting. Yet another agent is that of telomerase inhibition with imetelstat. Dr. Mascarenhas presented these results at ASH 2018, and this has been a drug that's been around for quite a while in our field. The concept here is that can you treat patients with relapse refractory disease, and even in the absence of overwhelming amounts of IWGMRT strict response criteria, which must last 12 weeks or longer, can there be an overall survival benefit or other benefit? And again, importantly here, as I've shown you in several of these other programs, as we start to think about our own field, you see a better than expected overall survival benefit here, median follow-up of 27.5 months with median overall survival as shown here. Importantly, 30 months in the 9.4 milligram per kilogram group. Again, I ask the question to be provocative, but also to think as we head into 2021, should we not be thinking about overall survival as possibly even a primary endpoint in those patients who've received one or more prior therapies? And in fact, this program and others are looking at that as the consideration for primary endpoints as they move into the later stages of study development. So as we conclude this talk, what we really are looking at in 2020 and beyond in the completely beyond JAK inhibitor single agent space is, again, thinking about promotion of apoptosis cell death pathways. I showed you our own data from the SMAC mimetic IAP antagonist LCL 161. So that was the oral agent, 30% overall response rate in 50 patients treated. BCL-XL inhibition with the Navitoclax agent, ongoing multi-center phase 2 trial. It'll be very important to see how this agent performs both as a single agent and in combination, both relapse refractory and frontline settings. We talked about targeting the microenvironment and the stem cell population with CD123 inhibition with the SL401 data. I showed you our data from EHA, the ongoing study. I didn't mention the HSP90 or MDM2 inhibition programs, which really could have their own separate talk with the amount of preclinical rationale and translational work still in the early stages of clinical trial development. And then as we think about future directions for this field, I'm really excited in general for our field of MF with all of these novel agents trying to hit from different vantage points. Fibrosis with the PRM151 story, cytokine epigenetic pathways, aurora kinase inhibition, LSD1 inhibition. Some of these agents have been given either breakthrough designation pathways or other fast track pathways for consideration for approval and other strategies. And we talked about telomerase inhibition. And then what about older drugs? Intriguing to think about interferon, CombiPeg, and other studies with ruxolitinib, as has been discussed earlier in the meeting, metformin, so thinking about inflammation in our patients with MF and as solo agents or in combination with JAK inhibitors. So really, truly exciting development of agents in the last few years. And then as I conclude, as you all know, I'm so happy that we were able to get together for this first of its kind virtual meeting. I was invited at EHA to also give a talk on the hashtag MPNSM experience, which many of you have contributed to. That's our grassroots Twitter program. And just to highlight to each other at this investigator meeting how important it is to keep getting the word out there for our patients, for advocates, pharmaceutical partners, ourselves as experts to talk to each other. And this experience now almost 5 years old of the hashtag MPNSM, myeloproliferative neoplasm on social media, has really been one of the great joys of my career to interact with all of you, to get ideas, collaborations, and to discuss ideas, debates, and controversies in real time. And I think this meeting is really the natural product out of that interaction that we've had. And so with all of this, I'd like to conclude and say thank you very much for your time and attention, and happy to have further discussions in the panel meeting. Thank you very much.
Welcome, everybody. It's wonderful to be here today to host this panel. As you know, we're in the module where we're talking about beyond JAK inhibitor or in addition to JAK2 inhibitor therapy. And I'm joined by our wonderful speakers, Lucia, Masarova, and Naveen Pavaraju. And it's been really a fantastic meeting so far. And this session particularly was just bursting open with possibilities for our patients. So we have a number of questions and we have about 15 minutes before we have to move on to the next module. I'd like to start with any comments, first of all, from Lucia or Naveen. The first question we have is any incidence on JAK2 in lymphoid disorders such as T-cell lymphoblastic lymphoma or leukemia, and the benefit of targeting this in such a context. And I guess I would really pitch this to Naveen and to Lucia, since you've published really fascinating work about this. Naveen?
So I think this is a really important concept. Lucia and I have researched this with our group over a number of different years. I think there's 3 important factors here, and Lucia, I'd be curious to see what your take is in 2020. Factor 1 is we already know, Lucia and others have published, that MPNs coexist with other malignancies, period. Dr. Moliterno showed that in her earlier slides. And that includes other heme malignancies and lymphoid malignancies. So MPN and CLL, MPN lymphoma, that was already a thing before the JAK inhibitors. Number two, in this paper by our European colleagues that really showed an increased incidence of lymphoma and JAK inhibitors. It was a shocking report to many of us, and Jean-Jacques and others who are part of this conference can comment more. And so we looked into our database to see if that was the case, and we didn't find that. We didn't see a statistically significant difference of the sequence of MPN, JAK inhibitor, and then lymphoma. There was a nice editorial by Rumi to show that this is an ongoing debate and controversy in our field and that more studies will be needed. It's actually a very interesting topic. And then the third factor, which is the one of discussion that our European colleagues brought up, Allison, is that could there be a pre-lymphoid clone, something like an immune globulin heavy chain G rearrangement or some other pre-lymphoid state? Really, that's never been discussed in any of our fields before. That could that be identified in the MPN patient, either pre-JAK inhibitor or not, that can then go on, sort of an L-CUS or an L-chip, whatever you like, for lymphoid. That I think is very important, and we really need to see if we can characterize that. Lucia, I'd like to turn it to you to get your thoughts. But basically, in our MD Anderson experience, published in Blood a year ago, didn't see a big association with JAK inhibitors and lymphoma, but there is one in the disease itself.
Right. Thank you so much. Yeah, I completely second you, Naveen. We have shown that just because of the myeloproliferative neoplasm, these patients do have increased incidence of other cancers. There has been multiple beautiful, even case cohort prospective studies from Sweden, Finland, Europe, which showed tons of patients. And the incidence of other cancers, especially lymphoma, for example, patients with myelofibrosis, had been almost fourfold higher regardless of anything. Right. So that speaks towards the first one. Yes, we should be more vigilant and monitor these patients because they could develop secondary malignancy either preceding or following the MPN. Because in our original paper, I think from 2015, we actually have reported on both occasions, people who had lymphoma and develop MPN and vice versa. So that is very common that we have to be all aware of. In terms of the ruxolitinib, that's a very, very, very intriguing question. And I also agree that the data are not solid. We have not seen any significant increased incidence in patients who would take ruxolitinib. There were actually data, this EHA, if you've noticed, from Francesca Polandri and a couple other people, evaluating over 500 patients also on ruxolitinib, and they actually haven't even observed lymphoid malignancy in these people. So that's also something to check on and keep in mind that the ruxolitinib unlikely is the culprit rather than the MPN that the patient had. And then the last question was well, I just lost my
utility of JAK2 well, you know, if the mutation is part of the pathogenesis of the T cell lymphoblastic lymphoma or leukemia.
Right. So thanks. So for example, the paper that Naveen talked about from Parpazzi last year, after which we look at our database, actually reported that 3 patients of those who had lymphoid malignancy had a detectable clone prior MPN. So that speaks about that sequencing these patients ahead of it. And we actually could see that there was a clonality preceding the MPN and the ruxolitinib. The question would be, does the concurrent MPN, which followed this existence clone, speed up the development, or if patients were on ruxolitinib, put them in a higher risk? And I cannot really answer that question. But I think it's not really common. It's more rare. So if it happens, it would be as any other myelosuppressive therapy, which could just select the clone, regardless of what we do.
Wonderful, thank you. I have a question to you, Lucia, about the really fascinating studies. And I think one of the questions that you presented about this, again, helping a JAK2 inhibitor be more potent, right, with these combination therapies. And one of the questions gets to this also, that any idea whether you know, the highest JAK2 allele burdens are in post-PVMF, for instance, and those individuals have a lot of JAK2 signaling. As I mentioned, if you put a lot of JAK2 signaling in a mouse, you'll really get the big spleen and the myelofibrosis phenotype. And in your studies where we're trying to capitalize on enhancing a Rux effect, do you have any association with the better responders being perhaps the post-PVMF group that may represent that very high JAK signaling? Do you have any idea of whether genomics informed the responses that you saw in your combination therapies?
That's a fantastic question, I would say. I would say that has been certainly reported in a JAK inhibition. So the more proliferative patients would benefit more because that's just what the JAK does. On the contrary, patients who developed low counts did have, although similar responses. The question may be the durability and whether we are actually using the same drugs for the same phenotype, and we don't, because if patients have more cytopenias, we may more benefit from other JAK inhibition, which has been already shown yesterday, but they target different pathways. In terms of the novel agents, especially the CPI-610, that would be fantastic to see. And I'm actually really looking forward to see that. If somebody takes those patients and actually shows, because it comes with the question, when we have the suboptimal responders, is it related to the proliferative phenotype where the dose wasn't enough to keep the disease responding and something just blew off and unleashed? And that could help us to see whether basically the patients had even that picture in increasing their allele burden. So if the additional target from a different mechanism would add on top of it, I certainly don't know at this point. The interesting data about interferon, for example, from EHA, that people showed affecting not only JAK2, but also TET2 mutations and TET2 allele burden, although they haven't really been shown to be pathogenesis in there. But that actually speaks that the deeper we target, the better we can get. But I'm not aware of these translating into any outcome as of this point. So certainly people involved in the trials shall evaluate this and let us know. We will be happy to learn.
Wonderful, and I want to get to, we just have a few more minutes, a couple of really important questions about the spleen responses and even using spleen response as our measure in these studies, which as we all understand is such a surrogate. And so from one, we have Naveen. I understand the need for pharma to get approval of drugs by using spleen and TSS, but is that an inadequate target for drug approval? That is a very low bar. And this kind of feeds in also to again, does it give us pause that the CPI 0610 is impressive in terms of spleen volume response, but we have to recognize that we got pretty good responses with comfort as usual, right, with Ruxolitinib. So
right.
Maybe if you could take this on.
I think it's a yes and no answer. So I think it's an astute question. My general take, and it may be a bit controversial in our field, but I think in the frontline setting, it's been outstanding to use spleen and symptoms, particularly as pioneered in the COMFORT trials and we've seen in the Jakarta studies for fedratinib. So that's been great. But as this question is asking, in the suboptimal and relapse refractory beyond JAK inhibitor, I'm not so sure, guys. I think that overall survival is what we should really be aiming for. Interestingly, in the field, we know that when you fail a JAK inhibitor or truly intolerant, and or clonal evolution, gosh, overall survival, median overall survival in a lot of our studies, Dr. Kirkendall showed, Dr. Verstovsek here, 14 to 16 months, Dr. Palandri and our Italian colleagues showed maybe up to 28 months. So maybe 2-year overall survival in many of these patients. I would advocate exactly as the questioner is asking, that rather than focusing simply on spleen and symptoms, in the second line setting and beyond, particularly for non-JAK inhibitors, by the way, I think we should be looking at OS, PFS, progression-free survival, and in combination with spleen and symptoms. I also think we should be looking at blast count as well in the bone marrow. Lucia has done some great studies really parsing out peripheral blasts versus bone marrow blasts and the potential significance of that. So Allison, Lucia, I turn it back to you guys, but I really think that spleen and symptoms don't tell the whole story in the beyond JAK inhibitor landscape anymore.
I totally agree. I would just add to it that the very important point would be the durability of the responses we can achieve. where is it going to be more superior? Because
Right.
we know the median duration of response to single agent. So we certainly want to see some improvements, especially for people who would not be eligible for transplant. Because once they fail the combo, we're going to be in trouble. So that would be another thing. And then plus, we all hope we'll find drugs that could halt the progression, because that's what we all fear. Having them with accelerated phase or bombastic phase is the worst that could happen. So if we could basically design or find out that one, that would be fantastic. So yeah, I agree that the simple spleen and symptoms may not be sufficient enough to compromise toxicity if it's a front line. And if it's a second or another line, what do we want to achieve in patients who are either eligible or not eligible for transplant? So for those not eligible, we certainly want to get the best responses, but also the longest responses. For those eligible, we want to have the best responses at the deepest level, and then do the transplant to possibly get rid of it. So there will be also something to add to the endpoints, where the quality of life, absolutely.
Well, this has been a wonderful discussion and some really great questions from our attendees. I think we are now at our time limit, so I want to thank everyone for participating and my panelists today. And let's move on.
Thank you very much. It's been fantastic.
Bye-bye.
Bye, everybody.
Thank you. Bye.